Dr. Barnes here, founder of Mindful Medicine. Welcome to part 2 of the Mood Stabilizer lecture. Consider this also a bonus lecture while we'll go through every medication. I thought it'd be kind of fun and interesting to give you kind of quick tidbits and pointers on each medication. So here we go. The antipsychotics we went through also, you can see that lecture, as we did lithium. So we're really going to focus on this middle category here. Lamictal, first, before I even jump in, I want to say that when you call something a mood stabilizer, remember, you're saying that it treats both depression and mania, ups and downs. But in reality, you can ask anybody that takes these medications or any doctor that's prescribed them, they'll tell you that it's really hard for one of these to be good at both. And in reality, most of the medications are very good at either the mania or the depression, and rarely both. Lamictal is a really good example of that. So Lamictal is probably better for the depressed part of bipolar and not so much for the elevated symptoms like mania or similar. The biggest thing that people probably remember about Lamictal is something called Stevens-Johnson syndrome. And Stevens-Johnson syndrome is a systemic, really almost autoimmune process where the body attacks itself, and it recognizes the medication as an antigen, essentially. And since the medication goes everywhere, your body attacks everywhere. The most notable place that it attacks is the skin, because you could see that. But you really need to understand that this happens in every organ in the body and is a medical emergency. These folks with Stevens-Johnson syndrome do have the skin rash that is classically talked about. But remember, they look febrile, they look septic, and these folks will need IV steroids and be admitted to the hospital. So how do we avoid that with Lamictal? We go painfully slow. Basically, you titrate very, very slowly, and this avoids the rash, in my experience, almost always. You don't get the rash or the Stevens-Johnson syndrome if you titrate slowly. This is probably why this medication fell out of favor in the field of neurology, because when you're treating seizures, you have to treat quicker as opposed to mood. So that's Lamictal and Stevens-Johnson syndrome. Depakote. Depakote is a stronger version, probably better for the mania as opposed to the depression. It does cause more things like weight gain and other side effects. It's heavier on the liver and does require some blood monitoring to check the level. And it has some implications in females who want to have babies. You have to be very, very careful. But it is a more powerful medication which could help things like aggression, anger, agitation better. Carbamazepine Tegretol, this one is good used historically, but the problem with that one is that it's a CYP inducer. So it basically, the way I look at it is it kind of eats up other medications that are with it because it will hypermetabolize other medications. But otherwise, it's a good medication that can be used in many different settings, along with Trileptal. Trileptal doesn't do the CYP inducing as much, and it doesn't have that consideration, but is also a very good mood stabilizer. Topamax people like because it treats migraines, and it's one of them that does not cause weight gain and has been studied in weight loss in certain individuals. So this is a fan favorite, I suppose, because of that. You do have to stay very hydrated because you can cause things like kidney stones, which is you have to keep in mind. And then gabapentin, which I learned when I did one of my videos, that it's a little bit of a controversial medication. But the way we use it in psychiatry is as a mood stabilizer, potentially to treat seizures when you're detoxing people off of alcohol, etc. Hit me up in the comments.